Welcome all who are virtually attending my abstract presentation. I'm Captain Elissa Beebe, General Surgery Physician Assistant, and I'm both honored and excited to be presenting my research on tranexamic acid risk evaluation in combat casualties 2. The standard DoD disclaimer and SAGE's disclosure applies to this research. I have no relationships or conflicts to disclose. Beginning with a couple key terms, tranexamic acid is an antifibrinolytic agent that prevents dissolution of a fibrin clot, which aids in hemostasis. Massive transfusion is defined as 10 or more units of blood, usually packed red blood cells, administered within 24 hours. The purpose of the study is to determine if TXA use in acute hemorrhagic trauma increases the incidence of thromboembolic events in active duty service members. TXA use in trauma was not widely used until the CRASH-2 study was published in 2010. This prospective trial enrolled over 20,000 adult trauma patients with or at risk of significant bleeding. The primary outcome was death. The study compared a placebo with TXA, and the results showed a significantly reduced mortality at 28 days when TXA was given. The MATTER study is a retrospective study that assessed whether the CRASH-2 findings were applicable to military trauma systems in Afghanistan, the first study to examine TXA use in wartime injury. This study compared TXA versus no TXA administration in 896 admitted combat patients who received at least 1 unit of blood. The main outcomes of the study were mortality and the rate of thromboembolic complications. The results confirmed the findings in the CRASH-2 study, as it reported a reduction in 30-day mortality in the group that received TXA. This study did demonstrate a 12% increased risk of development of a VTE in patients who received the TXA. The first TRECC study was conducted with the purpose of determining if TXA use was associated with an increased risk of thromboembolic events within 30 days of administration in severely injured U.S. military combat casualties when administered with a massive transfusion. This was a retrospective study with the primary outcome being the occurrence of thromboembolic events, DVT or PE, and the secondary outcome being mortality. Primary outcome results demonstrated a higher rate of thromboembolic events in those who received TXA. However, this was not found to be statistically significant. The recent retrospective study titled Evaluation of Military Use of Tranexamic Acid and Associated Thromboembolic Events by Johnston et al. Was conducted to determine the appropriateness of TXA administration and to determine if TXA was associated with VTEs. This study reviewed 455 U.S. military casualties from 2011 to 2015 in combat support hospitals in Afghanistan and a single U.S. military treatment facility, and TXA was found to be an independent risk factor for VTE. So what's missing? While some articles in current literature have identified adverse outcomes, they have used a limited surveillance period of 1 month after the administration of TXA. There have been no studies with a primary objective to evaluate the long-term risk of TXA administration beyond 30 days. Therefore, we hypothesized that combat trauma patients who had received TXA with a massive transfusion would have an increased incidence of thromboembolic events within the first year after administration compared to those who received massive transfusion alone. The primary outcome measure was the development of a thromboembolic event, DVT or PE, up to 1 year after the injury in patients who did and did not receive TXA with a massive transfusion. Secondary outcome measures were morbidity and mortality up to 1 year after administration of TXA. The TRECC-2 study is a quantitative retrospective multi-cohort study approved by the BAMC IRB. Inclusion criteria consisted of U.S. active duty service members with a history of hemorrhagic trauma with an injury severity score, or ISS, of 10 or more, treated with a massive transfusion with or without TXA in Afghanistan from 1 January 2009 to 31 December 2014. 859 records were returned from the DoD TR staff, but 218 of those did not meet inclusion criteria, so the number included in the study was 641. 314 received TXA, and 327 did not, meeting our pre-study power analysis goal. The demographics of the members in our study were evenly distributed between the two treatment groups besides the ISS. There was similar age, gender, type of injury, amount of blood products received, vital signs, and labs between the two groups. There was a statistically significant increase of ISS in the TXA group, indicating a more injured population in the group that required TXA administration. 24% of the patients who received TXA had a PE or DVT, and 21% of the patients who did not receive TXA had a PE or DVT. Chi-square analysis was conducted, revealing a non-significant p-value of 0.5125. We also compared TXA to DVT and PE separately, both of which were not significant. TXA versus any complication was not found to be significantly different. TXA was then analyzed separately against each complication with no significant difference found, except for there being a statistically significant higher incidence of TBI in those who received TXA. Although there were fewer deaths in the TXA group, this was not found to be significantly lower. This was the only study designed to assess the incidence of thromboembolic events in combat trauma patients treated with TXA from 30 days to 1 year. While there was an increased documented number of thromboembolic events in patients treated with TXA, statistical analysis did not show a significant difference. This lack of significant difference in thromboembolic complications in our study coincide with current literature, with the exception of the Johnston et al. Study that was the first published study to report TXA to be an independent risk factor for VTE. Documented mortality 30 days to 1 year was decreased in those who received TXA, similar to what prior studies found within 30 days of administration, although in this extended study, the results were not found to be significantly different. Although there was a statistically significant increased incidence of TBIs in the group that received TXA, this is likely due to that group being more severely injured. A limitation in this study is the potential violation of assumptions, since the research team assumed the databases were accurate and complete. This study evaluated active duty service members deployed to Afghanistan, an overall healthy population, making it not very generalizable to the general population. Another limitation is bias, to include bias from the researchers and biostatisticians who are gathering the data and variables. For example, ICD-9 and ICD-10 codes are used to determine the incidence of VTEs. These diagnoses may be categorized as a few different codes, and the researchers may pull codes that are vague, assuming it was a true VTE when it may not have been. In our combat injured population, patients who received TXA with massive transfusion did not have a significantly increased incidence of thromboembolic events within the first year after drug administration compared to those who received massive transfusion alone. Therefore, recommendations against the use of TXA in this population cannot be made on the basis of increased risk of thromboembolic events alone. We feel this supports its continued use in the combat injured trauma patient, specifically those who receive massive transfusion. As our study was adequately powered, therefore closing the current gap in literature, we feel additional research in this particular trauma population regarding long-term VTE risk related to TXA use to be of low yield. Thank you for your time and attention. This concludes my presentation. Please feel free to email me with any questions you may have.